and a very warm welcome to all of you linking into this APMENxChange webinar. This is a joint contribution by the World Health Organization and the Asia Pacific Malaria Elimination Network, APMEN. I am Kamini Mendis, Chair of the WHO Technical Advisory Group on Malaria Elimination and Certification. I'm also a Professor Emeritus of the University of Colombo and an independent consultant for malaria from Sri Lanka. WHO, founded in 1948, is the United Nations agency that connects nations, partners, and people to promote health, keep the world safe, and serve the vulnerable people so that everyone, everywhere can attain the highest levels of health. APMEN in 2017 has been hosted by the Asia Pacific Leaders Malaria Alliance, APMEN for short. This arrangement enables APMEN to support national malaria programs by bringing more resources through shared technical expertise and by fostering peer-to-peer learning and evidence generation. All this supports APMEN's efforts for high-level advocacy for political action against malaria. Now, prevention of re-establishment of malaria, we call it POR for short, is one of the specific goals of WHO's Global Technical Strategy for Malaria, and it was endorsed by the World Health Assembly in 2015. In the past couple of decades, many countries in the Asia-Pacific region, as well as in other parts of the world, have been rapidly progressing towards malaria elimination. However, the risk of re-establishment of malaria transmission remains a major concern. This is because the countries have the malaria vector in them, and there is a high degree of population movement which increases the risk of importing malaria into the country. Some of them also have weak surveillance systems, and to add to these problems, there's climate change and health system challenges. So, in response to these risks, WHO recently released global guidance on prevention of re-establishment of malaria transmission. The guidance provides critical technical direction for near elimination and post-elimination settings. WHO and APMEN are co-hosting this high-level webinar to introduce the POR guidance to support dissemination and country-level implementation. Now, before we begin, let me quickly go over a few housekeeping notes. This webinar is being recorded, and the recording will be made available to everyone. A link to access it will be shared in the chat box. We will not be taking live questions during this webinar, but we encourage you to submit your questions in the Q&A box. We'll do our best to address as many questions as possible during the Q&A discussion. When you submit a question, please start with the name of the panelist you're directing it to. This will make the process of responding much more efficient. We will, in this seminar, have 3 speakers who will deliver back-to-back, followed by a dedicated Q&A session and a quick poll at the end. Let me now introduce the panelists. Our first speaker is Dr. Daniel Gamije Madandi. He is the director of the WHO Malaria and Neglected Tropical Diseases Department. He was a former Minister of Health of Rwanda, where he led the development and implementation of the health sector strategic plan, as well as the country's comprehensive COVID-19 response plan. Dr. Daniel also served as co-chair of the Pandemic Fund and is a member of the Global Preparedness Monitoring Board. Our next speaker is Dr. Xiao Hong Li. She is a technical officer at the WHO Malaria and Neglected Tropical Diseases Department in Geneva. She has, in fact, led the development of the global guidance on POR malaria which we are going to discuss today. She has played an instrumental role in redesigning the WHO malaria-free certification process and has coordinated the certification process in over 10 countries. She previously worked for more than 10 years at the National Institute of Parasitic Diseases in the Chinese CDC. Our final speaker is Mrs. Maria de Rosario de Fatima Mota. Mrs. Maria works with WHO in Timor-Leste and previously served as the head of the Communicable Diseases Department, Control Department, and as the National Malaria Elimination Focal Point in Timor-Leste. In that position, she played a key role in guiding Timor-Leste's transition from malaria control to elimination. And she continues to champion cross-border collaboration, digital health innovation, and capacity building to sustain the country's malaria-free status. So those are our three panelists today. And now I would like to invite the Director of WHO Malaria and Neglected Tropical Diseases Department, Dr. Daniel Madandi, for the introduction and high-level overview of the global guidance on POR. Dr. Daniel, it's a pleasure to have you here, and over to you.
Thank you, Dr. Kamini. Dear Dr. Maria, dear Dr. Hong, dear colleagues and all participants to this webinar, good morning and good afternoon, wherever you are. On behalf of the organization, I'm pleased to welcome you to this webinar, which we are co-hosting together with the Asia Pacific Malaria Elimination Network. We are delighted to convene this important conversation focused on strategies to sustain malaria elimination. As many of you know well, WHO recently released its first ever global guidance on preventing the reestablishment of malaria. The guidance recommends fundamental role of health services and the accessibility to all in need, a well-functioning surveillance system, an effective vector control mechanism, cross-border actions, and finally, intersectoral collaboration to address risk factors. This vital resource is designed to support countries that have successfully eliminated malaria or are approaching that important milestone. I want to take this moment to congratulate Timor-Leste and Dr. Maria particularly, and all health authorities of the country for their recent big achievement. And I want also to congratulate Sri Lanka that you represent in this meeting, Dr. Kamini, that I visited some years ago, for demonstrating that prevention for establishment is something possible and feasible. In 2025 alone, WHO certified 3 additional countries as malaria-free: Georgia, Suriname, and Timor-Leste. To date, a total of 47 countries and 1 territory have been awarded a malaria-free status. Overall, more than 100 countries are free of malaria. These achievements represent an extraordinary progress, but they're also coming with responsibility to prevent resurgence. Today's discussion is an opportunity to explore how WHO new guidance can be applied in different contexts and to learn from one another experiences that we all have. I hope this webinar will set foundations for strong collaboration and will inspire innovative approaches to safeguard malaria elimination. Many thanks to all malaria experts attending this webinar for your presentation that you'll provide. Once again, thanks to all participants for joining timely this important exchange, and especially for your commitment to fight malaria. I thank you all.
Dr. Daniel, thank you very much for your insightful remarks and for setting the stage for today's webinar. Your reflections provide an excellent foundation for our discussions today, and we truly appreciate your time and leadership. Thank you. Now, our next speaker is Dr. Xiao Hong Li. She's going to share the key components of WHO guidance on POR of malaria transmission. Over to you, Dr. Hong.
Thank you, Kamini. Can you see my screen?
Yes.
Yes, but if it can be put on the presentation mode, it would be better. Great.
Yeah.
Perfect.
Is it in the presentation mode now?
Yes.
Yeah.
Okay. Thank you. Good morning, good afternoon, dear colleagues, dear friends. It is my pleasure to be here with you today to introduce the global guidance on prevention of re-establishment. So before I dive in the content of the guidance, let me just provide you a little bit background, building on what Daniel had just said. So this is the first ever global guidance on prevention of re-establishment. As you know, the WHO malaria program has a history of more than 7 decades. The question is why it has taken so long. Well, we'll have to review the history starting from the Global Malaria Eradication Program led by WHO. So in those times, malaria elimination was actively pursued, and the prevention of re-establishment was also on the agenda of WHO. In 1960, WHO created the official register, which marked the birth of WHO malaria-free certification. In 1973, as the countries and regions experienced resurgence, prevention of re-establishment was added as the second criteria for certification, meaning at the beginning, certification only had one criteria. At that time, it was already recognized the challenges that countries are facing for prevention of re-establishment is different from malaria control and elimination. The preparation of guidance for prevention of re-establishment was underway, but it didn't come out. It didn't come out, why? Because after the abandon of the eradication program, malaria elimination was no longer a global malaria goal. In fact, from 1986 to 2006, for 20 years, no countries were certified malaria-free, not because no country achieved elimination, but WHO stopped these services. In fact, the global malaria strategy launched in 1992 was called control strategy. It was until 2015, the global technical strategy for malaria, 2016-2030, we brought back the malaria elimination to the global agenda for malaria. For the first time, prevention of re-establishment is defined as one of the global malaria goals. And as you know, there are 4 GTS goals, and both malaria elimination and prevention of re-establishment are 2 specific targets. It is an important background of this guidance, but also very important background, very much related our current situation. And I thought that will be relevant to reflect this history as we enter into a very challenging and complex time in global health. So, content. We have 6 chapters in this guidance. Executive summary provide a high-level recommendation for prevention of re-establishment. Introduction describe the background, the objective, and the target audience. Another important background, which Daniel and Kamini had already mentioned, is that more and more countries in the tropical and subtropical regions have achieving and or very close to elimination In these countries, the challenges to maintain malaria-free status is expected to be greater than those countries that achieve elimination during the eradication era. Chapter 2 is biological and epidemiological basis. This chapter is not guidance per se. It explains and illustrates key concepts and terminologies for prevention of reestablishment. It is important that we explain these key concepts and terminologies to bring all readers, regardless of their background, to the same page. The real guidance starts from chapter 3, which is to apply the concept of receptivity and the risk importation and to prevent reestablishment. Chapter 4 provides detailed guidance on the strategies and interventions that can be used for prevention of reestablishment. Chapter 5 is planning, management, and oversight, which is equally important, if not more important, than strategies and intervention. And finally, we have a small chapter provide guidance on how to develop a plan for prevention of re-establishment. So key concepts. Malaria elimination is defined as the interruption of local transmission of a specified malaria parasite in a defined geographical area as a result of deliberate activities. Continued measures to prevent re-establishment of transmission are required. Re-establishment of malaria transmission is the occurrence of indigenous malaria cases in a country or area where the disease had previously been eliminated. We have another definition, which is WHO's operational definition of re-establishment. This is the occurrence of at least 3 indigenous cases of the same species in the same focus for 3 consecutive years. So this definition is defined primarily for decertification purpose. This is to encourage countries to take into actions so that they do not lose the certification. Countries are not we are not advising countries should not use this definition as a goal for prevention of re-establishment. Prevention of re-establishment should focus on preventing introduced and indigenous cases. Figure 2 illustrates the differences of imported, introduced, and indigenous cases. This figure is identical to what we have published in the elimination framework. A few very important terminology: receptivity, which is the degree to which an ecosystem in a given area at a given time allows for the transmission of malaria. This means receptivity is change over time. Risk importation, which is also called vulnerability in the past, is the probability of influx of infected individuals or infective Anopheles mosquitoes. The combination of the 2 concepts, receptivity and risk importation, is called risk of re-establishment, also called the malariogenic potential. We have another important concept called infectivity. Infectivity, also referred to as susceptibility or compatibility. It is the ability of Anopheles mosquitoes to support the development of Plasmodium until the mosquito has infective sporozoites in its salivary glands. So this is the first time WHO introduced infectivity in our guidance. Although the terminology exists, infectivity is an important component of receptivity. So what does it mean? Figure 3 tries to illustrate the differences in infectivity in the different pairs of Plasmodium and Anopheles. For example, Anopheles atroparvus, this is a European Anopheles. Anopheles atroparvus can transmit local or indigenous falciparum, the falciparum that circulated in Europe when Europe has malaria transmission. But it cannot transmit the falciparum from South Sahara region. So this has important implication in programmatic actions. So this is also very important terminology. Table 1 provides the data and information the country can be used to assess or monitor receptivity and risk importation. We don't have time to go through all these different information. Countries select different information or data to monitor receptivity depending on their context, whether they are relevant to your context. Just one very important point that the performance of a health system, also called the programmatic factors, can directly or indirectly influence receptivity and risk importation. So for example, the degradation of vector control, the declining of vigilance on malaria can increase the risk of reestablishment. Chapter 3, this chapter talk about how do we transit from malaria elimination to prevention of reestablishment. What's the common? What is common and what are the differences of the two stages? Prevention of reestablishment requires the management of the risk. In order to manage the risk, we need to understand the risk. So we have two extremes in the spectrum of risk. The stability of malaria elimination in some places, and why it's very challenging to maintain elimination in others. For example, in areas with a very high malariogenic potential. A typical example is border area. Applying this concept to prevent reestablishment, meaning we need to monitor receptivity and the risk of importation because the risk is dynamic. We need to apply risk stratification for planning and to tailor our response. And if renewed local transmission, we hope we don't have renewed local transmission, but if that occur, we need to use this concept to identify the contribute factors. Figure 4, this is an example from Egypt, which they identify the risk factors in each village and to guide the field actions. Table 2 is a good collection of the renewed local transmission after malaria elimination. So it can happen. It can happen in tropical and subtropical regions. It also happens in regions that with a very temperate climate. For example, in Moscow. Chapter 4 is about strategies and interventions for prevention of reestablishment. The strategies and intervention for prevention of reestablishment are not very different from those in malaria control. So the emphasis here is that we provide those most relevant or very important guidance for prevention of reestablishment without repeating what have already been said in other WHO guidance. So we are making reference to other WHO existent guidance. For example, the surveillance manual, the elimination framework, the malaria guidelines. Surveillance. Surveillance is the most important strategy for prevention of reestablishment. Early detection, prompt notification, timely treatment and response to every malaria case is the foundation of preventing reestablishment. In other words, if we cannot maintain good surveillance, we're going to fail preventing the malaria reestablishment. In the context of prevent POR, surveillance should be flexible, should adapt to the local context. That we need to consider the effectiveness of the general health services, whether they are able to timely detect all malaria cases. And we also need to consider the risk factors that affecting the malariogenic potential. Maintain entomological surveillance is also very important because we need to monitor the change of receptivity to guide our response. Entomological surveillance activities, and what do we need to do? And that, again, is context specific. We need to determine what we're going to do based on our context. So the guidance do not provide a single recommendation. We provide different options, and countries might determine your entomological surveillance activities according to your context. As in malaria control and elimination, the analysis of use of data is important in order to have a tailored response. So how do we respond to imported cases? Figure 5 provides a framework that for countries to consider and to how to assess the risk of importation and then to decide the response. Again, we don't have a universal answer whether we should do reactive case detection, whether we should do reactive vector control. We need to look at our data, and we also need to assess the resource available. Delivering quality clinical care is very critical, not only for preventing reestablishment, but also for avoiding unnecessary deaths. It's very common, unfortunately, that many malaria-free countries report malaria deaths. So after elimination, the clinical vigilance is expected to decline. So this is going to happen because the physicians are not going to see one malaria patient in a whole year. They're not going to remember malaria all the times. So what we need to do is put into the strategies and interventions to maintain the alertness and knowledge of malaria among the healthcare providers. Should it be training or monitoring their performance and whether they are using the suspected case definition? So this is what was discussed, what is discussed in this section. This section also discussed in the POR setting, how do we provide quality assured diagnosis and treatment, and what are the practical considerations? Again, there's no a single recommendation, but we discussed the different options. What are the pros and cons? For example, where should we keep the malaria test? Where we should use a referral system? Where we should use RDT? And where we should maintain microscopy? There's no single answer, but we provided different options and discussed them, and countries should make their own, base this discussion, and make their own decision. Other intervention and strategies to mitigate the risk of reestablishment. Vector control. So vector control such as bed nets and IRS should not be a routine intervention in general. It should be phased out after elimination. However, there are exceptions. In the areas with high malariogenic potential, you may need to continue this vector control. Even the vector control is no longer implemented as a routine intervention. Countries maintain the capacity to deploy quality assured vector control in case of outbreak. Inter-country information sharing and cross-border collaboration, which is very much discussed in different meetings, conference. So managing malaria importation is the responsibility of the respective governments. However, inter-country information sharing will help the receiving countries to improve preparedness. In the situation of border malaria, cross-border collaboration is important. It's an important component to address the challenges in border malaria. So box 1 provides the guidance. How do we differentiating border malaria from malaria importation to inform cross-border collaboration? So the box 1 provides what is the definition of border malaria. So this is the shared transmission focus or shared transmission zone. What are the features of border malaria? What is the geographical scope? And for example, a person take plane to arrive in a country that's not border malaria. And then we provide the recommendation for cross-border collaboration in such a situation. Outbreak detection, preparedness, and response. So this is a very important component of the program for prevention of reestablishment. So we provide guidance, how do we define an outbreak in the setting of POR? Again, although we recommend that one introduced case is an outbreak, the countries might use a more not so stringent definition for economy reason. And similarly, the guidance also discuss different options of outbreak response in POR settings. Should it be a routine program functions, or should it be placed under health security or emergency framework? Again, we provide different options and a concrete country example so that you might use to determine your own modality. Planning, management, and oversight. So one very important topic for POR is integration. So integration is an approach, is not the end. And after elimination, countries should integrate malaria activities into other general health services or other public health programs. The guidance provides the key principles that countries should consider when they plan or implement integration. So again, we don't have time to go through all of these, but this is just the key principles that we highlighted in the guidance. Leadership, also very critical. Political commitment must translate into human and financial resources. This is very critical for maintaining malaria-free status. But leadership is not only about human financial resources. The box 2 is a real-life example that is selected because it illustrates all the critical components of public health leadership that we expect countries to have for prevention of reestablishment. Multi-sectoral collaboration and community engagement, also very important. They are important for the effectiveness and the sustainability of the interventions for prevention of reestablishment. So the roles of other sector department in prevention of reestablishment is summarized in table 3. So many sectors and ministries have a role to play or have a responsibility in prevention of reestablishment. And they could have a role in monitor the change in receptivity, the change in risk of importation, or they can contribute to implementation. Public health workforce, this is very critical. This is the key to the success of prevention of reestablishment, whether we can maintain a competent public health workforce. Figure 6 illustrates the composition of the public health workforce for prevention of reestablishment. So after elimination, we don't have a malaria program, but we recommend countries should maintain, at least at the national level, a core team, a core malaria team, or a technical nucleus. So the function of this core team, we also provide some guidance on what are the expected functions of this core team. This core team might work on multiple diseases, but we recommend the country should maintain at least at the national level. And this is based on many countries' experience and lessons, and it is important to have this core team, at least at the national level. And finally, we have several annexes. The most important one is Annex 4, the core indicators for prevention of reestablishment. These are very carefully selected indicators that countries should consider when they implement the program for prevention of resurgence. And so finally, I wanted to say that the guidance is developed in the format that highlighting principles, key concepts with illustration of real-life examples. It's very frequently that we are using cross-reference because the topics sometimes fall into different thematic area. For example, the guidance for border malaria can be found in chapter 3 and in chapter 4 and an annex. So, and when you read the guidance, and you can find that one topic can be related to in different thematic sections. I think I will stop here. Thank you very much. Over to you, Kamini. Thank you.
Thank you very much, Hong, for your excellent presentation and for stressing the importance of POR. And as you said, this is the very first time that WHO has provided published guidance on this subject. So it's all the more important. So I think it's important that you stressed the strategies for surveillance, the quality of clinical care and outbreak management to address the importation risks and receptivity. You also highlighted the planning, management, and oversight, and that will be very valuable and applicable to countries that are at risk of re-establishment. Thank you again, Hong. Now, our final presenter is Mrs. Maria Mota, who's an accomplished and respected expert who will share her insights on country perspectives and challenges for the POR of malaria in Timor-Leste. As was mentioned by Dr. Danielle, Timor-Leste was recently certified by WHO as a malaria-free country, an achievement which is credited, at least in part, to Maria Mota, who led the country's malaria program to this milestone. So it's a pleasure to have you with us today, Maria, and over to you.
Thank you, Professor Kamini. Dear, good morning and good afternoon to all the participants who are in the meeting. Dear Dr. Daniel, Dr. Hon, and Professor Kamini, as well all the representatives from different countries. So it's my honor to share the country perspective on malaria prevention and the challenges that Timor-Leste face during the implementations of the prevention and reestablishment. So Timor-Leste, the goals for the POR, it was clear. So our goal was to maintain zero indigenous and targeted by 2025. And we have to prevent the establishment of the transmissions of the malaria and to sustain the zero malaria death. And ultimately, our goal is to achieve the WHO malaria certification, which has been mentioned that recently we have achieved it. To reach this goal, our national malaria program has adopted the global technical strategy pillars. We focus on surveillance and vigilance, case management of malaria and prevention, and then adopted the research being carried out in the country and use of the innovative tools for diagnosis and treatment and enabling the environmental. In terms of the status of malaria situation in the country over the last 2 decades, Timor-Leste has made remarkable progress. We have reduced the malaria burden significantly. However, malaria remains still potential to be treated. So our tropical climate, rains, trains, and cross-border movement with the neighbor country still continue to place as a risk for preventing malaria. In terms of the challenge in Timor-Leste for the preventing of transmission of malaria, allow me to highlight some of the few critical challenges that we faced before in preventing the transmission. In terms of the geographical barrier, we have many communities are living in the remote area, in the high-risk area, making difficult to deliver the diagnosis and treatment and vector control intervention. In terms of the cross-border risk, continuous movement of the people across the Timor-Leste has shared border with Indonesia, so expose malaria-free area to the imported of the infection. We also have a gap in surveillance. While our notification system exists, and we have implemented the real-time reporting in terms of the case and focus investigation accurately and determine limited of data sources in some places. Entomology monitoring, still we have to expand it to the receptive area where we have not been covered. Another challenge is the vector control resistant, potentially resistance to the insecticide, since in the region could undermine our prevention tools. In terms of the health system limitation, as you all know, that Timor-Leste is a very new country, and we had a lot of issue in terms of the geographical. Although we have improved, our system still faces a challenge in the human resource and logistics for sustaining the financial for malaria. To over outcome of those challenges, we have a priority strategy to be implemented in order to maintain our free malaria status in the country. Our progress has only made possible through a strong partnership with the WHO, Global Fund for the funding, Rotarian as one of our partners for the long term has been supported malaria. And of course, we have APMEN, the Network for Malaria in the Southeast Asia region and Asia Pacific. Continuing the international collaboration, sustaining the financing and operational research is very essential to protect gains and ensure the certification. So collaboration between the countries in the Asia Pacific region is very critical for the malaria elimination, especially we considering the transboundary natural in the disease. Sustainability of the funding is very important and very essential for Timor-Leste to sustain the malaria elimination. So we use the approach, innovative approach, such public-private. So we engage the public-private sectors, partners, donor support to securing the long-term continuation program beyond the initial success. So before to conclude my sharing experience of our perspective in the country, Timor-Leste journey has shown the malaria elimination is possible. I think we are possible, but it's still fragile. Preventing the reestablishment require high vigilance, innovative tool is very important, and also solidarity for the implementation. Without this, we will not be able to achieve our goal, what we have been set. So I like to take call of all of us, countries, partners, and the global leaders to continue work together. So by sharing lessons, strengthen the cross-border action, especially the country in the border with sharing border with different countries, and to support each other, it's very important. So we can sustain the progress and make malaria elimination to be reality in our region. I think thanks, that's all my talking point for this afternoon. And again, thank you for inviting me to be part of this very important event. Over to you, Professor Kamini.
Thank you very much, Mrs. Maria, for that, for sharing your experiences of what the challenges are of keeping Timor-Leste malaria free. It's not been very long since the country was certified, and yet you outlined so many very important challenges that you face in sustaining the malaria-free status. And I'm sure many countries, people from many countries listening in will will agree with you that it is indeed a challenge. Thanks again, Maria. Now we will move on to the panel discussion and Q&A session. I would like to kindly request all presenters to turn on their videos. And now let's step into the wisdom of our expert panel to uncover a few more insights. I'll start with some pre-prepared questions, and that will be followed by questions from the audience. So the first question, let me direct it to Dr. Daniel. Dr. Daniel, given the recent WHO guidance on POR that has been published and the certification of new malaria-free countries, what do you think are the most critical policy and operational gaps in sustaining malaria-free status globally? And how should countries prioritize their resources to address these gaps in the face of emerging threats, especially such as climate change and population movement and so on? And of course, given that malaria is no longer a major problem in the country, which is really a fundamental issue. Over to you, Dr. Daniel.
Thank you, Professor Kamini, for the question. And once again, thank you to Maria, Dr. Maria, for sharing her experience in the whole process of getting Timor-Leste certified as malaria-free country. As I did in my presentation, I recalled important pillars. Dr. Hong also insisted on it, important pillars for countries to ensure that their status is preserved and there is no reestablishment of transmission. So what challenges that countries are facing are multiple, especially with the reduction of the funding landscape. The access to services globally can be compromised due to reduction of resources, especially access to primary health care in remote areas where intervention like home-based management of malaria can be affected by the lack of diagnostic tests, rapid tests, but also treatment if further investment are not made, at least to make sure that imported cases are detected as soon as possible and treated. So it means access to services to detect imported cases for countries where already the disease is eliminated is key. But also, I noted that strong surveillance system globally should be reinforced. There is a tendency of less investing in disease surveillance due to the fact that the disease is no longer a public health issue in that country. I think having it integrated in the global country health system surveillance is key. And of course, there's some focused expertise in malaria surveillance. This is a problem that I found in different countries where colleagues who have been involved specifically in malaria, they feel that they are no longer important, they are no longer useful to the system, and there is a risk of losing expertise from the health system because they might convert their work to other area of work. So leaders at the Ministry of Health in the malaria program or in infection disease program, because in most of countries you have malaria integrated to other infection disease program, should take initiative to preserve the people with expertise in malaria, and they are able to be multitasked and be converted and keep the capacity to keep watching what the situation regarding malaria surveillance. So I want to insist in innovation in terms of strategies to preserve and retain experts in malaria, although the disease the country is declared malaria-free country. It's a big challenge to preserve and retain people with expertise in malaria. Another challenge is multi-sectoral response, because risk factors are from different sectors. Environment that you mentioned, especially with the climate change. Malaria, you can't fight it and win the battle if you are not with a multi-sectoral response. So we have several sectors which should be in part of the response. And to reach even the status of malaria elimination, you can't make it without other sectors, definitely. So it's good to preserve their involvement, although the country is declared a malaria-free country, by sharing them information on imported cases that are coming, how they were detected, and when, and how the response was effective, falsifiable transmission, if there is any falsely identified, and how the response was conducted. So you keep them involved in knowing what is happening and how the Ministry of Health, the malaria program, was able to respond. So, and the last, it's about advocacy for domestic resources. We do have so many priorities in health sectors, but again, considering the impact of malaria in terms of bringing poverty, it's a disease of poverty, but it's a disease also which brings poverty for families which are affected. This is an argument for advocacy to make sure that sectors like Ministry of Finance and Budget, they can still allocate some resources, but also some initiative globally for increasing resources for malaria program are given. Those resources are given so that we don't necessarily rely 100% to external donors or external support, even for key commodities like being able to acquire diagnostic tests and medicine. And I want to end to that component. I know it's very hard to preserve a certain level of stock regarding rapid tests and drugs because there is a risk of expiry if you don't have, you have reduction of patients. But if there is a way of tracking reasonable level of minimum stock that can be used to detect any imported cases and respond. So you need some resources to acquire those commodities, at least for part of detection and response capacity for a country where malaria have been declared eliminated. So let me pause here. Maybe I will comment later if there is another question. Thank you.
Thank you very much, Dr. Daniel. I fully agree that one of the most frightening challenges is the loss of expertise within the country. I mean, people forget, the younger generations stop working on malaria for good reason. There is no disease in the country, and as a result, it's really a major issue to sustain an interest among the medical profession, scientists, and others in malaria. So we all agree that this is a very important thing. Malaria elimination is one thing, but sustaining it, it's no point eliminating malaria unless this country can sustain it, because it's a huge effort to do that. There's a question from the audience, Dr. Daniel, is whether, and this is in recognizing how important it is to prevent re-establishment. They want to know whether WHO will be committed to an ongoing effort to help the countries on POR of malaria. We would like to know whether
Yes.
that will be committed.
WHO remains committed to support countries to preserve re-establishment of transmission. First, even through ongoing restructuring process, I'm happy to inform the audience that we have a position through Dr. Hong, specifically in charge for preventing a reestablishment of transmission of malaria in all these countries where the disease have been declared eliminated. So we have it in our organigram, the new organigram, despite the pressure we had for fitting in this budget space. So we're able to retain this important position because we believe if we need to achieve GTS targets, and part of this GTS target, we have elimination of malaria and preserve reestablishment of malaria transmission. So we are consistent with global objective and goals that we do have by putting aside human resources for that. And the technical support also will be provided through my team here, Hong and other colleagues who will be in charge of it. And of course, advocacy for more financial resources for critical activities like mission to assess any trend of resurgence. Recently, she was in one African country where we suspected abnormal increase of cases. So we'll keep providing technical assistance and we'll advocate for more financial resources from traditional partners to preserve this important achievement that we don't want to lose for any reason. So our commitment is assured.
Thank you, Dr. Daniel. So that's reassuring. And I think the fact that POR features in your new organogram is testimony to the fact that WHO will be committed to providing support on this. I have a question now for Dr. Hong from the audience. Dr. Hong, the question, let me read it out. Would you be able to elaborate a little on what the guidance describes can and should be done in this civil society sector? It wasn't in the table shown. And or lessons learned on this from the review that informed the guidance development. Dr. Hong, is that clear? Is that?
Well, I'll try. So if I understand correctly, that is about the multi-sectoral collaboration, the role of civil society, and that's not featured in the table that we put together. So the table 3 is just a generic guidance that what we see in many countries. These are the sectors that have an important role to play. It's not meant to be descriptive, meaning there are many other sectors that also have a role to play to maintain malaria-free status. And depending on which country, some sectors are more important than the others. So to answer the question of this colleague, the civil society, do they have a role to play? They have a very important role to play. For example, it just come back from an African country, as Daniel mentioned. Civil society, as they are close to the community, they have can do advocacy to advocate the community, the population about the risk of malaria, many roles and many roles that direct to lead the communities to engage them in detecting the risk of resettlement, the change of the environment, many roles to play. And I think depending on which country, and it can have a leading role in guiding this effort in the society, in the community, in preventing of resettlement. So, and I just wanted to clarify, this table is not meant to be descriptive, and we recognize in different countries the different sectors. As a ministry, I have might have the set of ministry or sectors will be different in terms of their role in prevention of resettlement, and which countries. Some countries, the agriculture and water resource management department have a very important role to play, while the other, tourism, is very important. And it could be in some country, which I can verify that civil society have a very important role. So I don't know whether I answered that question or not. Thank you.
Yes, thank you. Thank you. And if I may sort of briefly add to that, I mean, this is a real major challenge because people in the country have forgotten malaria. And how does one keep them engaged? I mean, living here in Sri Lanka, which is about 11 years now after elimination of malaria, and I can see how very difficult it is to engage civil society and keeping the memory of malaria alive. But I think again, Hong, and to the person in the audience who asked this question, I think there are certain civil society groups or risk groups that have to be the focus of attention, like travelers who go out of the country to endemic parts of the world and come back. I mean, those are the ones that really need to know that they are at risk of malaria. So, I mean, So it's an ongoing challenge. Thank you, Dr. Hong. Now there's another question from the audience to Dr. Daniel this time, and they ask, how can the private sector engage in the POR process, and how to effectively mobilize the private sector contribution to POR? And it is directed to Dr. Daniel, but I would appreciate it if also Dr. Hong wants to respond to that as well.
So I think it depends with countries. There are countries where private sector plays a key role in providing health services through private clinics, etc. And other countries, maybe their role is not so huge. Means public health sector is everywhere. I mean, you have health facilities that are faith-based or government-owned health facilities reaching to the maximum of the population. So depend the country, but globally, the private sector, they have their role in terms of providing services. Means they need to know, they need to be also trained, knowing that there is a new status in the country. The malaria has been declared eliminated in the country, but there is possibility of imported cases. Anyone coming from abroad presenting malaria symptoms, going straight to a private clinic should be diagnosed, treated, and reported. And therefore, the entire mechanism for active surveillance can be initiated around the person who have been confirmed malaria as imported cases. The same if it was a patient treated in a public care facility. So I think part of efforts in capacity building, we should invest also in capacity building for private clinic providers in care, but also in reporting, in the surveillance system, so that we don't miss any information just because the patient was treated in private sector. Second level of involvement, facilitating the private sector access to commodities, because to avoid that, then you have a parallel system of fake product, and effective product. So the Ministry of Health, the malaria program has responsibility to be assured that tools that are used in the private sector are meeting WHO and country standards to avoid we are missing cases just because of the poor quality of tools that are used there. I think the rest, I again emphasize on a kind of task force at the country level for preventing reestablishment of malaria transmission, a multi-discipline sectors representation, where malaria program or what remains in the Ministry of Health, still in charge of malaria, will be organizing that kind of task force and will be closely in touch with them for updating, sharing information, making refresher courses, etc., etc. It's important aspect, including representative from private sector and civil societies organs.
So as you said, Dr. Daniel, the private sector, health sector is extremely important in the POR phase. Some of the countries I know have ensured that there is no malaria medicines in the private sector, and that is solely in the government sector, whereas diagnosis is possible in the private sector. This is to ensure that all the cases are notified. But I mean, here in Sri Lanka, it's working very well. The private sector, hospitals, laboratories always report when they detect a case. So I think there is a lot to think about when engaging the private sector. As you said, the regulation of the quality of diagnostics, RDTs, medicines, and all that. So thank you. Thank you for that. Now there's a question for Mrs. Maria. And the question is there any report on outdoor transmission, and how is it addressed to prevent re-establishment? And how to integrate malaria surveillance into the country surveillance? Maria, over to you.
Thank you, Professor Kamini. Yes, there is a outdoor transmission, especially during the certifications process, and also in the last 2 years. However, in the country, we have actually set up an entomological team at the national and also at the municipality level. So they are conducting the routine monitoring, including monitoring of the vectors in the country, including they also monitoring the insecticide resistance, as the country has been apply distributions of the yellow line with 80% of the coverage, especially in the raised malaria area. And also we did also in the residual spraying. So that's very important for us to monitor the vectors and also the resistance level. In terms of the surveillance, since the country now, as we all discussed, that when you go for the malaria certification, people might think that malaria is over and we don't have to do anything. So one step that we do is that we try to engage with the political level, and we also do socializations of this importance of the post-eliminations of the malaria in the country through the all the level at the national, municipality, and also ground level. So we have actually, country has started we call it the family program in initial when the country since 2015, and then currently government has changed the program to, we call it integrated program intervention, which involve all the medical teams and also the other health professional who doing the monitoring. So one of the objective is not to leave people behind to access to health facilities. So this program, so we integrated this malaria into this program by providing the rapid diagnosis test. So when they go for family visit or home monitoring, so any fever cases they found, so they can do a test. And they also will bring drugs also with them, so they can do on-spot treatment to the patients without delaying. So we are thinking of preventing the death of the people, especially during this time. And at the same time, we continue distributions of the line through this activity as well, and also monitoring of the, especially in the area where we have the intervention, to continue monitoring the number to the household where has been where has been conducted the residual spray. So that's a step that we try to integrate this activity, the surveillance. At the same time, to strengthen the diagnosis and treatment. So we have the team, we have medical doctors and all. So without relying to the malaria officer, but they can continue activity, especially in the community level.
Thank you. Thank you, Maria. So integration is, I think, a key component in this phase. But I think Dr. Hong will emphasize this, I'm sure, that the guidance clearly says that integration of malaria services into the general health system and into other communicable disease programs should be done very cautiously and not rushed, because it can be a real hazard if it's too rushed and if it fails. So I think she will emphasize that during the discussion, I'm sure. Thank you, Dr. Maria. There's a question for Dr. Hong, which I'm sure she'll be very pleased to answer. Should POR interventions be carried out after elimination, or should it be started in elimination stage before reaching elimination? And why?
Okay, thank you. And that's a very important question.
Mm-hmm.
So, and if we look at the definition of elimination, it speaks to a geographical area, meaning that means prevention of reestablishment and start before the country achieve elimination nationwide, meaning that prevention of resettlement is not a concept that apply to the country as a whole, but it's based to subnational area. So for example, Timor-Leste now achieve nationwide elimination. The whole country is working on prevention of resettlement. Indonesia has not achieved national elimination yet, but they have achieved elimination in many subnational areas. They're actively working on subnational verification. Indonesia also need to prevent resettlement in the areas that already become malaria-free. Elimination and prevention of resettlement must go hand in hand because it's reversible. If you don't prevent, as Kamini said, if the elimination is not sustained, you go back to eliminate, interrupt transmission. So these two things, they are very much interrelated. They must go together. Thank you, Kamini. You're muted, Kamini.
I think we've had some very good questions from the audience, and we still have some time. So if the audience has any more questions, please direct them until we see more coming. One question, and this is directed to Hong again, which many people would have, is a question of how does one convince governments to invest, to keep investing in malaria, to prevent re-establishment, when the disease is no longer seen as a threat? And would you like to comment on that?
Yeah, I can comment on that, but I'm sure Kamini, yourself, and Maria have your very valuable experience. So I think that we have two angles that to explain, to advocate for malaria resources after elimination. So number one, no matter which country, it's very common that you will receive imported cases, meaning you have to treat the patient, otherwise patient will die. It doesn't matter whether they are imported cases, they are indigenous local cases, they will die. And as we have seen in many malaria-free countries, the case fatality can be even higher in malaria-free countries than endemic countries. That means you have to invest because it's the government's responsibility to look after people's health, right? So that means that you have to invest the whole surveillance system in order to timely detect and treat malaria patients. This is regardless of the risk. Even you have zero risk, we must do that. Number one. Number two, the risk of reestablishment that I think that we should be able to explain to the authorities, right? These vectors, normally elimination doesn't mean the elimination of vectors. The vectors continue to be present. Theoretically, it can happen, right? So we have already, as we have illustrated in our guidance, it happens in many countries, not only tropical or subtropical region, but even in an area like Moscow, decades after elimination, it can still happen. So I think that as technical person, we should be able to use these points to advocate for the resources for malaria. And I don't know whether, Kamini, you would like to share your insights from Sri Lanka.
Thanks, Hong. Yes, I mean, another aspect, if I may add, is that, you see, the savings that governments make by not having malaria is huge. And if malaria comes back, the cost to the government can be enormous. And I think that's an issue. That's something that advocates in the country have to emphasize again and again. Because if malaria returns to the country, it's going to be an enormous expenditure, not only in terms of financial finances, but also in terms of people's lives. Because these countries the people in these countries have lost immunity. And if malaria returns, it could really be extremely devastating to the country. So I think these are arguments that can be made. And I think Dr. Daniel also emphasized an important thing, that the country should, if at all possible, maintain an advocacy group or expert group of people who are overseeing malaria POR, and also act as advocacy, provide the link to the government and emphasize the need to sustain the malaria-free status, and that a financial investment, and it's generally quite small compared to malaria control, that it has to be sustained, and I think that's important. We still have a little time, so I don't see many more questions coming in. But can I ask Mrs. Maria to comment on your experience with the cross-border collaboration? Timor-Leste has a border with West Timor, and on the other side of that border, there is some transmission going on, and that is a continuing threat of introducing malaria to Timor-Leste. How are you dealing with that? And I know there have been some very effective steps taken by both countries to prevent a re-establishment. Maria?
Yes.
Would you like?
Yeah. In terms of the cross-border, actually, the initiate of the activity was started in 2017, and we have continuous the engagement with the colleagues from Indonesia. However, even we have some challenges, but actually we have a very good in collaboration. So when the country reported the cases, we share the information to the colleagues from Indonesia, and we also share what are the intervention that has been done in Timor-Leste side. In terms of, and also in terms of preventive. As we know, Timor-Leste, we have quite actually huge lot of population movement in the border time to time. So we have the agreement in 2019, have the face-to-face discussion with the local authority in Indonesia and also at the national level. However, since 2020, the COVID-19, we could not continue, but we do it virtually. So we have a discussion, and APMEN actually, thanks for APMEN also, has been recently linked the coordinations between Timor-Leste and Indonesia. So through the APMEN from the previous months, we have been able to discuss identify some of the important activity that has to be synchronized and implemented in both countries, especially Indonesia and Timor-Leste. And in that activity also, we were able to discuss to establish a task force for both countries, because we are taking the experience that we have facing from the last few years, that sometimes we have continuous discussion is quite challenging. So by having this task force involving of the direct implementation people and also the high-level people, for us to have quick interventions. So whenever we have any challenges in both sides, so it can be quick discuss, and we have to quick response to if any cases are reported in both sides. As we know, Timor-Leste, most of the cases that we have very recently reported is mainly in the border area. So at the same time, this task force actually led by the national directors, and also there is a member, and we involve partners also in the member. Of course, WHO also part of this activity as well. So this we continues implementing, and actually we have developed the cross-border framework, and we have shared with the colleagues from Indonesia. However, we need further discussion on this framework and continuous implementations through the WHO, both from country office of Timor-Leste, and of course we'll involve the CRO and also HQ level, and country office of Indonesia. So this framework is giving us very well details activity what has to be implemented for both country, and this has been shared. And we also actually have very recent training in this year, collaboration training for both country for the POR, prevention and reestablishment. It was very successful done. Thanks for Dr. Hong, and Dr. Jacinta was facilitating this activity. And both country was very happy has been conducted this, and we look forward for continuations for the collaboration in future.
Thank you. Thank you very much, Maria. That's a real success story, and let's hope that many other countries can follow. There's an interesting question here, an important one, I think. The question is, they want to know whether there are tools available to monitor clinicians' delivery of quality care management or best practices you can share. Hong, you want to have a go at this? Are there tools available to monitor clinicians' delivery of quality care and management?
Yes.
Yes.
I think it's included in the guidance. We cited online tool that was developed by the researchers that can use to monitor the performance of the clinicians, and country might use that tool to adapt to your situation. And that's and I think that's one thing that we can do. And another method is to sample the records, the physicians, the patients' records, and to see whether to review retrospectively whether the patient have met the suspected case definition and whether they have received a malaria test. So in the guidance, we have provided several methodology to monitor the performance of the clinician's performance.
Thank you. Hong, if I may add to that, Sri Lanka's experience, I think, is one of the most difficult challenges is delays in diagnosis of imported malaria. And every day that an imported malaria patient remains untreated, the risk of onward transmission and re-establishing malaria increases. So Sri Lanka has started monitoring the time to diagnosis in every malaria patient. The time from the onset of illness to the time that the patient seeks treatment, and from the time the patient seeks treatment to a diagnosis. And strangely, what we find here is that patients seek treatment quite early, although very often they are blamed for not seeking treatment. No, they seek treatment quite early. But on the part of the health system, there are huge delays sometimes in diagnosing malaria. For obvious reasons, malaria is no longer a common disease. Physicians forget this disease, and there are many other diseases that cause fever, like dengue and leptospirosis, viral diseases, and many. So malaria is not on their differential diagnosis list. As a result, there are delays. So I think it's important that countries monitor in every single imported malaria patient the time to diagnosis, and send back feedback to the attending physicians saying, look, this patient that you treated, you failed to diagnose early. It took 10 days for you to do a malaria test, and so on and so forth. So every single patient, so it's a matter of close monitoring.
Yeah, and Kamini, if I may, so what you just mentioned, the practice in Sri Lanka, is actually one of the core indicators we recommend countries to monitor the time from symptom onset to health seeking health seeking to diagnosis, confirm, and it is one of the indicators that countries should consider, and in the setting of POR, which is very important to monitor where the delay happens.
And the case fatality rate of malaria, I think, imported malaria, is very important, because when the case fatality rate begins to rise, then you're very sure that something is really wrong. There's a delay in diagnosis, or the physicians have not treated the patient properly, and so on. So I think on that note, we are fast approaching the limit, time limit for this webinar. Let me try and conclude, although I'm sure there are many other burning questions that people would like to ask. Just a minute. Okay. There is a poll to be shared. Okay. So now I would like to invite you all to participate in a quick Zoom evaluation poll. It will only take a few seconds if you haven't done it already, but your feedback will be very valuable to the APMEN team to better prepare future webinars. I'd like to conclude by thanking you very sincerely. First, our expert panelists, Dr. Daniel, Dr. Hong, and Ms. Maria, for their excellent presentations and invaluable insights. I'm confident that our audience has gained some practical knowledge on applying the guidance, WHO guidance on malaria POR, and this is an extremely important subject. Thank you to each of you for attending this webinar and contributing to it with your questions. Thank you again. Goodbye.
Thank you. Bye-bye.
Thank you.
Thank you. Bye.
Bye. Thank you so much.